Welcome, colleagues. Today, we're diving deep into an explainer that serves as a true clinical masterclass on affective disorders. If you're looking to bridge the gap between biological psychiatry and the profound, complex depths of the human mind that we actually encounter in our consulting rooms, you're exactly where you need to be. Look, we've all got the DSM-5 criteria memorized, right? But I can tell you from years of experience, moving beyond a mere symptom checklist to truly understand a living, breathing patient's internal world is what transforms us from simple diagnosticians into true healers. Our primary task is to ask what is really going on beneath the surface.
Here's our roadmap for today's session. We'll start with etiology, move into the psychodynamics of depression, cover treating bipolar and mania, tackle the psychodynamics of suicide, and wrap up with concrete clinical treatment strategies.
All right, let's kick things off with etiology, specifically looking at how biological vulnerabilities and environmental stressors collide. Because as we know, it's never just nature, and it's never just nurture.
Consider the breakdown of risk. We now understand that unipolar depression is roughly 40% genetic and 60% environmental. That makes major depressive illness an absolutely ideal clinical model for studying gene-environment interactions. You might have a patient with a genetic vulnerability just sitting there quietly, essentially waiting for a major life stressor to pull the trigger on a full-blown clinical syndrome. Take the 5-HTT serotonin transporter gene, for example. Think of genetic variations here like a volume dial on your patient's emotional sensitivity. If they have a specific polymorphism, they are highly sensitive to even low-threat stressful events. It's the same thing with the CRHR1 gene. It moderates how a person responds to childhood trauma, dictating whether they'll end up with a persistently hyperreactive stress response system alongside elevated ACTH.
And the neurobiological fallout from early trauma is profound. Depressed women with a history of childhood abuse actually have, on average, an 18% smaller left hippocampal volume compared to non-abuse depressed subjects. Plus, their CRF levels are consistently elevated. This trauma literally hardwires a neurobiological sensitivity into the brain. It lays dormant, basically just waiting for adult stressors to ignite a hyperactive stress response.
Okay, so that's the biological hardware. Now let's pivot to the software, diving into the complex internal world and the psychodynamics of depression.
We have to go back to Freud's classic 1917 essay, Mourning and Melancholia. He famously wrote that the shadow of the object falls upon the ego. When you hear relentless self-depreciation from the couch, you have to remember, this is often anger turned inward. The patient has unconsciously identified with a lost or abandoning object, usually a parent, taken it inside their own mind and redirected their rage right at themselves.
Building on that, clinician Silvano Arietti gave us the concept of the dominant other. This perfectly captures why our patients completely fall apart when living for someone else fails to get them the impossible validation they're desperately craving. It could be a demanding spouse or an all-consuming corporate career. When that dominant other vanishes, the patient's entire psychological scaffolding just collapses. Now, City-Blatt's distinction between anaclitic and introjective depression is an absolutely crucial clinical skill. You need to know this so you can anticipate which defense mechanisms are going to walk into your room. Anaclitic patients are desperate for nurture, terrified of abandonment, and lean heavily on denial. Introjective patients, on the other hand, are relentlessly self-critical, perfectionistic, and will deeply intellectualize their feelings of guilt and failure.
To really ground this, think of Miss J, a 49-year-old with severe psychotic depression. As a child, she was beaten by her father. As an adult, that abusive father became internalized into a vicious, harsh superego. As her therapist, you have to reframe her symptoms as an active, internal drama where a primitive, internal object is literally persecuting a bad self. For her, it eventually manifested as hallucinated voices demanding her death.
Let's shift gears to the other end of the affective spectrum and talk about the unique and frankly formidable challenges of treating bipolar disorder and mania.
Treating bipolar patients means dealing with a near-total lack of insight during and after manic episodes. They experience this profound psychic discontinuity, essentially arguing that their manic self has absolutely nothing to do with their euthymic self. They'll completely deny their destructive and aggressive behavior. Interestingly, we also see a strong link here to unresolved early parental loss. Your job is to help them weave these violently split, disconnected parts into a single, continuous life narrative.
Dr. K. Redfield Jamison captures this beautifully in her reflections on her own bipolar illness.
She reminds us exactly why exploring the psychological meaning of medication is just as vital as writing the prescription. If a patient refuses mood stabilizers and we just angrily label them non-compliant, we are failing them. Sometimes, refusing the pill is actually a defense mechanism against the terrifying vulnerability of hoping a cure might actually work.
This brings us to our highest-stakes clinical scenario, the psychodynamics of suicide. It's a tragedy deeply associated with major affective disorders and one we absolutely must be prepared for.
When you're assessing suicide risk, you must listen very carefully for what Ash called the hidden executor. This is an internal persecuting figure tormenting your patient. A suicide attempt isn't just a symptom. It is the fulfillment of an internal victim-tormentor drama. They feel so persecuted by their own mind that suicide feels like the only logical way to submit to or escape from the torture.
To manage this risk accurately, we have to look at short-term predictors for an attempt within a 1-year window. We're talking panic attacks, severe psychic anxiety, depressive turmoil with rapid mood switching, global insomnia, and alcohol abuse. When you see these acute signs in your office, your clinical alarm bells need to be ringing loudly. Do not ignore them.
But we have to separate those acute states from long-term risk factors like ideation, intent, and previous attempts. And here's the absolute key. Hopelessness is actually a much better long-term predictor of suicide risk than depression itself. This hopelessness comes from rigidly holding on to impossible expectations of what the self should be. When they can't meet those standards, despite trying, they simply conclude there's no point in going on.
And get this, there's an implicit cognitive association test that looks at unconscious biases linking words like death or suicide with the concept of me. That test predicts a staggering 6-fold increase in the odds of a suicide attempt in the next 6 months. That completely exceeds the predictive validity of many of our known risk factors. It just proves how deeply embedded these self-destructive associations are in the unconscious.
Let's bring all of this together now and look at actionable clinical treatment strategies for your daily practice.
There is a massive difference between managing suicide and actually treating the suicidal patient. Management is continuous observation, physical restraints, removing sharp objects. It's temporary protection. True treatment requires psychoanalytically understanding their internal factors and using medication to alter that fundamental wish to die. If we don't do the deeper work, they remain utterly vulnerable the second the observation stops.
And listen, doing this deep work takes an immense emotional toll on us. We've all had that help-rejecting complainer who demands help but shoots down every single suggestion, leaving you feeling totally impotent. We have to ruthlessly monitor our countertransference. We might unconsciously fall into malice, secretly wishing the patient would just die to end our own anxiety, or aversion, where we conveniently forget to check on them. On the flip side, beware the savior trap, where you delude yourself into thinking you can just magically love their depression away.
So what do we actually do? We abandon those legally useless no-suicide contracts. Instead, we empower our patients by collaboratively building a step-by-step safety plan. We teach them to recognize the warning signs, implement pre-planned coping strategies, reach out to specific friends for distraction, and remove lethal items themselves. We have to treat them as active, capable participants in their own survival.
I'll leave you with this final thought as you head back to your clinics. Our greatest tool isn't always a flawless verbal intervention or the perfect medication adjustment. Most of the time, it's our steadfast capacity to just sit in the darkness with our patients, courageously witnessing their terrifying internal worlds without rushing to falsely cheer them up. So, how will you use your therapeutic alliance to hold that dark space today?